Community Assessment of Lake County, California. I am Deborah Ard, registered nurse. I am a student at the University of San Francisco. This is a requirement for Nursing 505, Dr. Teresa O'Neill, instructor. The county boundaries. Basically, you have all of these lists of things and places and canyons and boundaries and stuff of Lake County. The only thing you got to remember about Lake County is the center of Lake County has a lake that takes up about a half of the county. It's the largest freshwater lake inside of California, or largest naturally occurring, I should say, freshwater lake occurring in California. It makes transportation around the county very difficult because to go from one end of the county to the other, you can't just go across the center. You have to go around the lake, and it's 110 miles around the lake. The other thing you have to remember about Lake County is on the northwest shore of the lake is a volcano that's about 1 million years old. The lake is about 2 million years old. The volcano, although it has not erupted in 10,000 years, is still active, has steam vents, and it's rated as likely or moderately likely risk of eruption by the local forestry service. Community assessment. With 21% of the residents over the age of 65, the county is nearly twice the proportion of older residents than California as a whole. The anticipated significant growth in this age group will put a larger burden on the healthcare system and local economy, which may not have sufficient community services or tax base to support. That is from Avid and Associates, 2010. They were a group that was commissioned by the county to do basically what I'm doing for the county right now, and that was a county assessment of needs. Lake County has the highest percentage of seniors covered by a combination of Medicare and Medi-Cal in the Northern and Sierra Counties region. It has the second lowest percentage of seniors that have private supplemental coverage in addition to Medicare, also by Avid and Associates. In a recent county survey of the 5 county healthcare needs identified by the focus group identified as representative of seniors, which was the Lakeport Senior Center, 3 of them tended to support the need for home health RN case managers and coordinators. Other focus points are transportation to appointments, affordable in-home support services or elder care, including respite services, and consistent long-term medical providers. Doctors come into this county, do 3 years or so by contract, and then go. They do not stay. And there are very, very few Medicare, Medi-Cal providers. Several of the recent focus group participants had complicated health needs and were frustrated with having to change doctors frequently due to providers leaving the area, as I said. The number of Lake County residents who will suffer functional disability due to chronic conditions of arthritis, stroke, diabetes, coronary artery disease, cancer, or cognitive impairment is expected to increase. A focus on preventative health and wellness has economic as well as quality of life payoffs, as the long-term benefits over a lifespan have been shown to be cost-effective. Population estimate as of 2012, 63,983. Number of households, 26,103. Adult illiteracy level, 12.9%. Major causes of illnesses: chronic liver disease, chronic lower lung disease, cancers, and diabetes. My first key respondent, my first interviewee, was an RN recently retired as a director of a medical surgical unit at a local hospital, acute care hospital. And she said, these were her points. Point 1, despite the best effort of her case managers, many patients return to the hospital for the same exacerbations of chronic conditions over and over again. She states that non-compliance with medications, polypharmacy, multiple providers, non-compliance with follow-up to doctor's office visits, and confusion about new medications all contribute to the readmissions for elderly patients with chronic conditions. That the Medicare allotted visits by home health for post-acute follow-up is not adequate for patients, particularly the elderly, to keep them from returning to the hospital, and that a home health visit at least weekly, indefinitely, or if not possible, a telephone call to both the caregiver and the patient at least weekly would be enormously beneficial to these patients. My second key respondent. Carl J. is an elderly, recently widowed World War II veteran who is being followed by the local VA clinic. Per Carl, he is healthier than many his age, which is 88, though he has recently had a cardiac shunt placed and has an ejection fraction of 26%, chronic renal insufficiency, and chronic urinary tract infections, and occasional falls. He has also complained of no communication between his cardiologist, paid for by a Medicare supplement, and the VA clinic, though they are across the street from each other, and each know that the other is following him. Carl wishes that he had a nurse just to call him weekly to see if he needs refills and or maybe to come back and check his blood pressure, as it is difficult for him to do this himself. The problem. Often residents who have multiple chronic conditions have irregular serial admissions to local hospitals without sustained improvement and with subsequent readmissions for the same presentations and conditions. These residents are most often elderly. What this means is an increase in debility after each admission, difficulty for the elderly to remain at home, high costs that cannot be regained under current Medicare or insurance standards, and increased mortality that just need not happen. Elderly chronic conditions and disease patients are receiving multiple acute admissions but not sustaining health after discharge. A solution indicated by the facts: support older adults to remain in their homes by using education of the patients and their caregivers, regular telephone and or home visits, coordination and case managed care between providers and specialist providers, to provide consistency in the medical team in a county that has high turnovers in medical providers. This will reduce admissions for chronic conditions. Basically, you're educating and empowering the patient, plus supporting them. The plan of correction. These are the 4 points, I should say, that states if the patient would be qualifying for this particular type of a plan for a home health following them. On or upon discharge from an acute hospital or from referral from a healthcare clinic, screening will be performed on selected elderly patients with chronic diseases conditions. First, if the patient has been admitted to the acute hospital for the same exacerbations within 90 days and or has had more than 3 appointments to the clinic for the same chronic conditions in the same time period, and or has missed 2 or more appointments with the primary specialist doctor in this time period, and or if any laboratory findings or doctor or nurse assessment suggests that the patient is not stabilizing and or improving from complication of chronic conditions, then the patient qualifies for admission to this pilot program. The plan of correction is there will be an initial visit or phone call from an RN case manager. What they will find out from the patient is their list of doctors, their home medication list, if they've had any change in their providers within the last 30 days. Type of transportation used to the primary or the specialist appointments will also be identified. Who their primaries and their specialists are, whether or not there's been a change. Referral to providers who use the patient's insurance or Medicare if there is no primary provider. The RN case manager will review for medication interactions or contraindications, as well as make recommendations for immunizations for patients unless it's contraindicated. On the first or second contact will be a home visit to assess the patient's health directly, their home environment for cleanliness and heating and cooling, their caregivers, if they have any, for knowledge and reliability, and family support or abuse, if any. If a caregiver is needed, the RN case manager will refer to the IHHS to find suitable caregivers for the time allowed. The RN will convey any pertinent information found in the 2-day survey of the patient to the primary doctor and the specialist and will identify each to one another. The RN case manager will have contact with the patient directly at least 3 days for at least 3 times the first week in order to make certain that information is consistent. This can be a direct visit or it can be phone call. There should be at least one direct visit though. The RN case manager will monitor nutrition, medication administration. Weekly boxes can be filled with medications and loaded that way. And then they also are going to be screened for polypharmacy or interactions. All visits to the patient will be documented in a legal medical record. Vital signs and systems assessment will be done for each visit, including condition of skin, teeth, and nutrition. If the RN case manager finds needs in any of these areas, it is to be addressed immediately with the primary and/or specialist, and a copy sent to the primary. As issues are identified and corrected, patient will not need as frequent a visit schedule. Eventually, the goal is to prevent further avoidable exacerbations of chronic health conditions and reduce visits to weekly, telephone, and monthly by the nurse to the residents. This can be changed at any time depending upon the patient's changes in condition. The benefits of this program: avoidance of unnecessary acute admissions and stabilization of chronic conditions. Avoidance of exposure of already challenged patients to acute nosocomial infections. Reductions of costs of care. Home case management is less expensive than acute admissions. Also, if a patient is, for Medicare and Medi-Cal, readmitted within a certain time period, I believe it's 30 days, for the same diagnosis, the hospital cannot reclaim most of the costs of the visit for a lot of conditions or certain key conditions. Another benefit is increased emotional well-being. Patients who ultimately may remain in their own homes and avoid skilled nursing admission. Empowerment of patients and caregivers who are taught to manage disease, not to have the chronic conditions manage them. Lastly, in a county, when primary and specialist doctors are transitory, the RN case manager is a stable entity in the patient's health. My references: